Hey everybody, welcome to our live session today. So I will just wait for Dr. Gadaleta to come in, or DJ. Awesome. Hey, everyone's coming in. All right, cool. So we'll hopefully have DJ come in soon. Dr. Buckbinder, how are you? It's good to see you. All right, DJ, come and request getting in the live here with me. Let me know if it's working there, DJ. Hey everybody, thanks for joining. We're going to start talking about rhinoplasty, having a good, fun discussion. Let me see if this is it. Yes. DJ, did that work? Oh.
All right. Looks like we're on.
All right.
Sweet.
Awesome.
How's everyone doing? Hello. I see our nurse is here, Dee.
Yes.
Good.
Awesome. All right, we're getting some people joining in. So,
Perfect.
I guess let's do 1 or 2 minutes before we get started on this stuff. I guess we can. I'm just going to call you DJ. Hopefully that's fine.
That's perfect.
So I'll say that DJ and I have been friends ever since our fellowship. We met in Philly. We've been kind of both had our connections to Philly for many different reasons, and we met in fellowship and kind of hit it off with a good friendship. And then we've done a lot of academic things together, and we probably text too much between each other, just asking things about cases and everything. And so
my wife calls you my COVID wife because we were spending so much time over COVID on the phone together.
Yeah, that's true. That's actually really funny. That is true. We talked a lot during COVID. So we thought it would be fun to kind of talk about things about rhinoplasty, and specifically the things that we, in terms of our perspective, what we're looking at for the patients, that things that we find really important and things that we talk to each of our patients about, and just give you an more interesting perspective, if you will. So we have kind of a list of things we're going to talk about, but I'll just quickly, since people might not know each other, but DJ, why don't you give, sorry, I kicked my ring stand. DJ, why don't you give kind of like a minute or so of like your background, your training, and what you love doing and where you are.
Yeah, so I'm from the East Coast. I'm from New York, originally from Long Island, and then basically did all my training on the East Coast. So I went to med school at Boston University, and then went down to Philadelphia for head and neck surgical training for 5 years, and then finished off with a fellowship in facial plastics and reconstruction at NYU. And then I met my wife when I was in Philly. She's from the San Francisco Bay Area, so we ended up moving out there and starting a family in San Francisco. So now I'm in practice with 3 office locations in the San Francisco Peninsula area, so Palo Alto, San Mateo, and Los Gatos. And
you have one young child.
I have a 4-month-old.
4-month-old.
Great first Christmas, so it was a really fun holiday with her, and we are still on vacation. I'm calling in from Colorado right now, so hopefully hitting the slopes after this discussion.
So one 4-month-old girl and one. How old's that mustache?
The mustache is only a week old, but it's strong.
Only a week old. Okay. So for anyone that doesn't know who I am, my name's Kirk Lozada. So I'm born and raised in Hawaii, and then I came all the way out to Philly for college at Penn. I met my wife at Penn, so we both met our wives. I met my wife in Philly. We've been together since college. I did med school at Jefferson, then did residency training in New York, then came back to Penn for my fellowship training, and then I got offered to kind of stick around at Penn and this ENT practice here. And so we've been doing our thing now. I now just moved and have a new house, and we have 3 little boys. So it's a crazy, crazy life that we live.
It's got to be crazy.
Right.
How you do it with the twins.
Yeah,
Even one is a lot.
It is, yes. All right, so let's start talking. So we have 5 things that we're going to talk about in rhinoplasty. So the 5 things that we look at that we find are really important, and that we certainly discuss with patients, but we want to talk about why they're important for you guys and why they're important for us. So I got number 1. Number 1 is skin thickness. All right, DJ, you want to go first, or you want me to go first?
Sure. I'll talk a little bit about when I'm looking at a patient and assessing skin thickness, what I'm thinking about. So in my head, I like to try and grade it from like a 1 to a 10. So just kind of like 1 being very thin, 10 being super thick. It's kind of funny because I think a lot of people don't realize that there's a lot of variability in people's skin thickness. And from person to person, that can change a lot. And for what's important for rhinoplasty is when we're building a structure, That structure is made out of, the bones and cartilage, the foundation of the nose. And then the blanket of soft tissue that lies over it reveals kind of the structure that we're building. So if you think about it, a person with very thin skin is going to show that structure a lot more clearly. Someone with thick skin, it's going to be a little harder to see kind of some of those subtle changes that we build out. The things that we can do to modify some of those things. So if someone's got severely thin skin, sometimes we do things where we borrow tissue from the temporalis fascia and we can place that on the nose before we close it up to try and help build up that soft tissue a little bit, so that there's always tiny little irregularities. I mean, we're building the structure out of biologic tissue, so we have to account for the fact that there's going to be irregularities, and sometimes we want to make sure that that's camouflaged by increasing a little soft tissue in the nose, so we can borrow from somewhere else and place that. On the other side of the spectrum, if someone has ultra thick skin, then it becomes really hard to do some finesse things with rhinoplasty, so we can actually thin out that tissue when we're doing our surgery to try and help show some of the structure a little bit more and create more definition. The other thing that I always talk about patients with is in terms of the recovery. So with someone with thin skin, I think about the skin and the soft tissue envelope almost like a sponge. So someone who's got very thick skin has more capacity to hold on to fluid. And so after, there's going to be a longer recovery to see some of that definition show through. So with all my patients that have really thick skin, I have a conversation with them before the surgery that, hey, this is going to take a while for that swelling to go down because your body's going to hold on to it for a little longer.
I'm the same way. I grade things from a 1 to a 10. I tell patients kind of where they are. I write it in my notes. And like you said, it's something that's so critical to understand, and that I really highlight for someone that's either on one end of the spectrum or the other about what the benefits are and what the limitations are for each of them. So for someone that's super thin skin, I say, look, you have the ability to get a lot of definition and things to show through your skin that other people with thicker skin can't, but you also have the downside of that every little tiny thing is going to potentially show through, and that's something that I'm fighting to deal with, right, too. So any little bump, any little thing. So on the flip side, people with really thick skin, I say, look, getting definition through your skin is a really hard task, if not impossible, to get like tons of definition. You cannot. I think that's the biggest thing, is that I want them to know that you cannot get a nose like a thin white girl who has like super thin one skin. You just can't get that, no matter what you do. Even if you make the most sharp angled nose underneath, that thick blanket of skin is just going to limit what you can get. So I think it's really good just to have them understand the limitations of what they can and can't do. There's certainly techniques that we try, like you said, camouflaging with crushed cartilage or cartilage paste or temporalis fascia. And then similarly on thick skin, trying to thin it out, or, like we do, both of us do similar things now where we're putting big grafts, trying to pull the skin up on thicker skin to get some better definition, but we're still limited. So it's the same thing with a lot of other things too. We can't give anyone any nose. We can only work with what you have. And skin thickness, I think, is the most important thing to start with, because I think it's the biggest determinant. I think that's where we start. My discussion starts with, look, this is your skin, and beyond that, we can do things, but I can't give you something that's not possible with what your skin is. So
right. Yeah, I think an attempt to do so that's where you get into trouble with unnatural results if you try to do something too extreme and try to change someone's natural anatomy more than you really should. And so I think in the history of rhinoplasty, we've learned a lot from our predecessors about kind of the ways we can change things to a certain degree, but obviously we have to say within certain boundaries that we're given with the baseline patient anatomy.
And like steroids, after a lot of people will use, like, we don't put it all over the nose for thicker skin for a lot of swelling. We put it in specific spots that we have. And then also, something that I don't do, and I don't think you do either, but there's a newer thing where people are using Accutane, right, to kind of thin skin out. So Accutane obviously used for acne in the dermatology world, but people are using that because it does help thin the skin envelope out after rhinoplasty. It's kind of a newer thing that people are doing, but there are certain things that people use. So I think that's a really good kind of like overarching thing of what we're thinking about in terms of skin thickness when we see people in the office. So anything else you want to mention on that, or should we go to number 2?
No, I think that covers it. Yeah.
All right, number 2. I have size of the dorsal hump.
Right.
All right, I guess I'll take that one first, maybe.
Sure.
And then you can chat. Okay. So obviously, dorsal hump is the bump on the bridge of the nose. That's probably the most common thing that we see in the office in terms of what people are wanting changed. They want to bring a bump down. So the size of the bump is actually pretty important. it really is critical in understanding what it is that we have to do and what we might have to do to make sure that things are going to be stable and things are going to be long lasting and not causing any problems in the future. Why is that important? The bump is usually, there's two components to it. There's the bone on top, and then there's the cartilage on the bottom. So when we're taking more and more bone because the hump is bigger and bigger, then it certainly can make a bigger gap in between, and we need to really bring the bones in together to close that. But I think the bigger issue, I think we both agree, is that it's in the middle part of the nose. So this middle third of the nose, the more and more bump you take down, meaning the more cartilage you're taking down, the more it destabilizes that area of the middle part of your nose. And that is a really critical place for breathing. And it's actually the area where you have the tightest spot in breathing. So it's called the internal nasal valve. And so when we bring a really big bump down, it becomes very critical because you're really destabilizing a lot of that area, and you really need to make sure that you reconstruct it so that you're not compromising someone's breathing later on or have that area collapse and have some things that are telltale signs of that happening in the future. I think it would dictate, honestly, I do a lot of scarless rhinoplasty, as you know, DJ. I think I've done a couple really big bumps that I've, in the middle of it, been like, I maybe should have opened this one, because I think you really need to have good mid-vault reconstruction with spreader grafts and doing something that you can really control as best as possible. Just because I was getting really close to the mucosa, and I was just like, this is close, and I think it's something I learned early on that I would change. So just simply because of the size of the bump, I would change my approach.
Right. Yeah. Very similar to you. I think that it's critical. I mean, I think one of the fun and challenging parts about rhinoplasty and what makes it so interesting, probably for both of us, is that when we're changing the look or the shape of the nose, especially with our background as ENT surgeons, we're always thinking about how it's going to affect the function. And I will never sacrifice, function for a certain aesthetic. It's just something that goes against kind of all my training. And I know ultimately, having breathing problems through the nose can really negatively affect quality of life significantly. So it's something that we're so aware of and we have to be thinking about for the patient, even though they're not necessarily aware of how those changes can affect the breathing in the nasal airway. So the hump, the size of the hump is pretty important, like you were suggesting. So if it's a small hump, we have ways of taking that down incrementally, basically by using certain kind of sanding instruments where we can kind of smooth out the hump. And in doing that, if it's something that's like small to medium, sometimes you can get away without, as Kirk said, moving the bones in. If it's a large hump, that's when I'll have the discussion with my patients that most likely this is going to require us to bring the bones in. Because if you think about it, the mid vault, or the part of where the hump is usually formed, is kind of like a roof like this, and we call it an open roof when we take down the hump, and basically now there's a gap between those bones. And so the only way to close that without feeling a gap there is to bring the bones in. So that's one of the indications for why we would break the bones for rhinoplasty. So that discussion is another discussion I have with my patients, just in terms of also counseling them for, what their postoperative experience is going to be like. I know if I'm going to break someone's bones, there's a much higher chance that they're going to have some black and blues that are going to be there for, maybe a week or so, that they're going to have a little bit more swelling. If it's a large hump too, there's a discussion about how it's going to take time for that space to kind of contract down. So when we take down the hump, if you think about it, now we have this basically excess skin that was kind of tented up on that hump. And it's going to take a few weeks for all that to kind of what I call shrink wrap back down to the form of the nose that we recreated. The hump, like you mentioned too, is critical for function. So the internal nasal valve is the most common area where people experience nasal obstruction. And if you think about it, it's where the septum meets the angle of the side walls of the nose. So it's like this, and we like it to be about 15 degrees. Sometimes people have such a high hump, and it's so tensioned that it actually makes that internal nasal valve a little cramped. And so actually by dropping a little bit of that, sometimes you get an improvement by doing that. But it is critical during that hump removal. It's not just as simple as taking down the hump. There has to be some reconstruction to rebuild the function and also make, you want basically a nice smooth profile, not only from the side profile, but from the front. You're looking at basically the brow, what we call the brow tip aesthetic line. And you want this line to go from the brow all the way to the tip defining point and be one smooth line. And so that's important. When we take down the hump, we have to think about, okay, do we need to put grafts in there to rebuild that or make that width appropriate and balanced with the rest of the nose?
I mean, I think that highlights so many important points and just goes to show how complicated things can be, and how many things we're thinking about all at once, like when we're looking at someone's nose in the office, right? And so these are the things that kind of change our approach and what kind of graphs we might be using or thinking or planning on using, or things that we might be worried about and that we're focused on that you might not even realize.
Right.
I have next on the list, number 3, as tip size and strength of cartilage of the tip. So, whoa, DJ's gone. All right. I guess I'll give it back to you. What do you, or unless you want me to say something about it, but I know
so yeah, I mean the tip is also a very complex region. I mean, it's a region of all rhinoplasty. We're thinking in 3 dimensions, and so you're thinking about how it's going to look from the front, how it's going to look from the side, how it's going to hold up in time, and we're trying to basically place this thing in space where it's a favorable angle and projection, how far it is off the face, and keep it there for 20, 30, 40, 50 years. And there's a ton of different ways to approach the tip, but in assessing the tip, it's important to kind of, I mean, we're feeling the nose, we're feeling, pushing it into the face, seeing how much spring there is to it. So one of the main support mechanisms of where the tip is in space and if it's drooping or not is basically just how strong those tip cartilages are. Some people have really robust, strong tip cartilage. You can push them in, they'll bounce right back. Some people, you push the nose in, it goes all the way into the face. And that, just doing that one test can tell us so much about how are we going to rebuild this? How are we going to address this tip? The essentials of the tip, I mean, we talk about the tip like a tripod. There's basically 3 arms to it. You have 2 lateral arms and one between the nostrils. And by affecting those legs of the tripod, we're affecting the tip position, both how far it is off the face and how rotated it is up and down. And having strength to your cartilage means that we can do a lot of things by just changing the conformation of those cartilages. If the cartilages are weak or they feel deformed or kind of, some people have just these really, over time, if you're doing a patient who's in their 50s, 60s, maybe 6th decade of life, their cartilage has been worn down over time and it's pretty flimsy. And you open it up sometimes you find out on the table, wow, this is a little bit worse than I thought. It's buckled in certain places. It might have a crack in it. They might have fractured their nose or got bumped in the nose and didn't realize it. And in those situations, you're going to have to reconstruct those tip cartilages by using certain grafts that we use. So we usually use either cartilage from the septum that we borrow, or sometimes we'll borrow cartilage from the ear, or sometimes even in a case where it might be a revision and we know that there's really a lack of cartilage, we'll even use some rib cartilage where we need a really robust source of strong cartilage to rebuild some of those things. So feeling the tip and kind of getting a sense of what the patient is looking for and what's possible is super important for us to kind of have a game plan. So every surgery, Kirk and I, we sit there and look at those pictures. I know I look at the pictures tons and tons before I get in the OR, and I'm recreating kind of, when I open up the nose, what am I going to see? And if I see this, how am I going to approach that? And basically with rhinoplasty, you have to have a million different plans in place for kind of what you're going to see on the table.
I always say it's like you have to have a big tool belt because not everything works all the time. So you need to know that this was your plan. And then if this doesn't give you what you're doing, then you kind of go to the next thing. And I'd say that most of our conversations too, I think are all about the tip, right? I mean, like this is what we talk about the most, I think, because it's the most difficult part. I think also what's important to, like DJ's pointing out of what the tip is and how we think about it, the old way of doing tip surgery was certainly like cutting things out. You have big tip, big structures, bulbous, whatever, then you would cut it out, cut some parts out of it, and then that would make it smaller, which it does, but there's a point that it can compromise support and breathing, and it can look pinched. And the problem is that sometimes it's still okay, and then other times it's not, and there's no clear way of knowing when it's going to be an issue, like if it's going to be 6 months later or 25 years later. And so the issue is that you can't, what we do now in like the modern techniques that we use, we're trying not to cut things out, if at all, really. And what we're trying to do is, instead of cutting the cartilage away that might be in excess, we're trying to hide it. We're trying to reshape those cartilages of your nose to give it a more pleasing shape while also supporting things like your breathing. And like that's a hard thing to do. And so I think what I've learned certainly too doing cases is that when someone has big cartilages and they're really strong, you're fighting a lot of things going against you and trying to reshape them in the way that you need to. And so it certainly changes what I think I might have to do what approach I might have to do, what grafting I might have to do, as opposed to someone who has, somewhat maybe a little bit weaker, a little bit more narrow, or their tip overall is pretty good and it's not too bad. Just something that I thought about. I saw someone yesterday who had very, very broad bulbous tip cartilages, and they were very strong, like very concave, very bulbous in the center. So much so that I was like, you would think early on that doing a little cephalic trim and doing some tip suture in the middle would do something. And it might, but in reality, I think we know now that it really won't. Like it's not going to do enough where she's going to be that happy, I think, with it. Maybe they would be, but certainly you and I wouldn't be.
Right.
And so, for that one, I was like really knowing that those strong cartilages are going to need probably, I said it, for me, I was like, we probably should do this open. We probably should be planning to do some lateral curl struts, if not cephalic turn-in flaps, to really put something that's going to flatten those cartilages out in a way that if you don't have that plan or you don't have that ready to go, it's not going to be as effective as what it would otherwise. So that for me, I think, is really critical of understanding. And then also knowing what you might be able to get away with. If they're stronger cartilages, you might be able to take some on that patient and it'll be okay, as opposed to someone who has weak cartilages and you really can't take any. And knowing that is really, really helpful.
Yeah.
So
we got a question about, someone asked about if the tip is the only thing that bothers me, is how would that look for rhinoplasty? And there are rhinoplasties basically that we classify as a tip rhinoplasty. It means that we're basically, there are a lot of people that don't have any other issues or aren't bothered by anything except for maybe a little bit of bulbosity on the tip or maybe a little bit of a droopy tip. And in those cases, I mean, it's still a rhinoplasty. It still requires a surgery to address. But it's a little bit more limited in terms of the recovery period, a little bit shorter when we're just doing tip rhinoplasty. And we can basically just make those changes in an isolated way without addressing anything else. So that is possible.
I will say, too, that this question comes up. And, I remember at one point, hearing something about Mike Nyack, where he was like, I almost never do a surgery where it's just like, one component on a rhinoplasty. And I kind of think he's right. I mean, there's certainly times where I've done something just specific, but it's tough that everything, like DJ said, everything is a three-dimensional structure in space that is playing off the other, which is why this is a very complex operation. You do one maneuver that's on one part of the nose, but what we find out is that when you do it, it has an effect on the other views of all space. And so it might have an unintended effect if you didn't plan for it. And so you have to compensate for that. Or it has if you're really slick and you're really good, then it has the right intended effect. Then you're maybe killing two birds with one stone or whatever it is. So, doing just something to the bridge. So here's a good example, right? You take someone's bump down on their bridge, it always will make their tip look long, always. So when you bring the bridge down, it'll always make the nose look longer. It's just the way that it plays with our eyes. And so if they just want their bridge untouched, or they don't want their tip touched, but they just want their bridge down, it may work if your nose is not too long. But if your nose is slightly long and we bring your bump down, now the tip's going to be long, and then all of a sudden that person's like, we can't leave it like that. And you're like, yeah, you can't. We got to do something. So it's very common that we need to touch most components to things.
Yeah. Which is why sometimes I find for those situations, I mean, morphing really does a great job, and that's a tool that we use a lot for rhinoplasty is taking our pre-op photos and morphing them in a Photoshop tool, so we can kind of show, okay, if we just took the tip down, this is what it's going to look like. And by doing that, you can see how all these little areas of the nose that we subdivide the nose into, they all have an effect off one another. So the human eye doesn't see just the hump; it sees the whole nose together. And when you remove a hump or you change the tip or anything like that, it's going to change the whole entire look of not only the nose, but the person's face. I mean, rhinoplasty, we say changing the nose changes the face more than anything else that we do with facial plastic surgery. So that's also a conversation I always have with my patients about expectations after surgery and kind of knowing and giving them the best kind of thoughts about how to feel after they have their surgery in terms of how their appearance might change.
All right, let's go to nasal. So I have number 4, twisted nose. Yeah. So the old twisted nose.
One of the most challenging parts, I would say, in rhinoplasty.
Yeah, right. So it's something that people talk about a lot. Very, very common, especially in my practice. And people, not that it's their fault, but people think that, just straighten it out a little bit. Like, it'll be no big deal, when what DJ said is accurate. I really tell people that's probably the most challenging thing to do in rhinoplasty is getting a nose perfectly straight. there's so many things that are playing a part of why your nose is twisted. A lot of times it's based on the septum. The septum is really the main driver of why things get twisted. But as you can imagine, a piece of cartilage or even, bones you can break and move and reshape, but cartilage is something that's mobile. It's got memory. It's got shape. So reshaping that to keep it in place long term is something that's very difficult. So having a person that's a very twisted nose, you have to first understand why it is twisted. And the more experienced you are, now I look at a twisted nose and I can already imagine what the inside looks like. And so when I look on the inside, I want that to confirm what my view on the outside is. And usually I'm not surprised, but that means that I understand why they're twisted. You have to understand why they're twisted to understand how to fix their twists.
Right.
So, and the only way to really fix twists reliably is to straighten and strengthen the structure of the nose of the cartilage of the septum. And that usually requires cartilage grafting. There's really no other way to really do it. Whether it's cartilage or bone, sometimes we can use too, but that is the thing. And so, I'll be honest, the scarless rhinoplasty, and you'll admit this too, right, is not the way to fix a twisted nose. I can do spreadografts internally. Not a lot of people can. Not the fake spreadografts. Sorry for anyone that thinks that the internal spreadografts are real, but real spreadografts, I can do them. They're really difficult, but I can do it. But it's just not as good and as controlled of doing that. Certainly I've never really done clocking stitches internally. I'm sure that would be a little difficult to do. I'm sure I could try it, but if someone's really twisted in that's what I try to judge in my consults. I say, what's your priority? If their priority is the cosmetic lateral profile view of the tip and the tip shape and the super tip break and all that looking really feminine and really nice, then that's great. But if someone's coming to me and they're like, listen, my number one goal is to get this thing as straight as possible, there's zero chance that I'm going to be doing a scarless rhinoplasty on them. I am going to open their nose and I'm going to prepare them for really restructuring everything with cartilage. So what do you think?
Yeah, I think you hit up a lot of good points there. Certainly, again, this is another area that function has to be considered. A lot of people, these twisted noses, crooked noses definitely impact the nasal airway and the breathing. So that's a conversation we have. But I always counsel my patients, getting the nose perfectly straight is impossible pretty much. I mean, think about it as impossible. No one's got a perfectly straight nose, and no one really is going to ever have a perfectly straight nose, especially when it starts off super crooked. And it doesn't matter if it's 2 millimeters off or, a centimeter off from the midline. Both of those scenarios present really challenging situations, and you are fighting against what you call a memory of the cartilage. So if your cartilage has been crooked for your whole entire life for 30, 40 years, something like that, and then we try to surgically straighten it, a lot of times that cartilage has still memory in it and it wants to go back to its position. So you might even get it perfectly straight on the operating table, and then 3-4 months later, it might start to shift just a little bit back. And so we can do things like massaging and things like that. But it's just important to have that conversation with the patient so they understand that, yeah, we can improve it, but to get it perfect is probably an unrealistic expectation. The other thing...
Right, it's straighter, not straight, right?
Yeah. And the other thing that comes up a lot, which I think people don't really realize until I show them their photos after I take them in, our first consultation, is that everyone's face is asymmetric. So sometimes you look at the nose and, yeah, it's off by 1 millimeter or 2, but then you realize, okay, the middle of their brow and their front teeth don't line up. And you're like, Where do we put the nose? Do we base it off the front of the teeth? Do we put it in between the brows? It's just going to have a natural slant to it because, again, there's people out there that have completely asymmetric faces, and everyone can do this on their phone. If they get one of those apps that provides they take the left side of their face and they duplicate it to the right, and you'll see that all of our faces have a little asymmetry to them.
I do that a lot too, and I think all of us do. But especially when you notice one nostril's higher than the other, something that you notice the alar base, and people bring it up and they want to know why. And then it's funny, I'll look and I'll point to them and I'll say, I jokingly say this, I was like, listen, you might hate me for this. I don't mean to rock your world, because it's kind of like a Matrix moment, and I'll be like, listen, one of your eye, inner part of your medial canthus is a little higher than the other. Your lip is a little higher than the other. It's the whole thing is a little bit off. And most people are like, oh yeah, but occasionally sometimes people are like, oh my God, you can tell that you just seismically changed the way that they see their face. So I hate doing that, but it's important so they understand, especially with little nostril differences. It's very tough to fix those, and they need to understand that there's limits for that. So
yeah, there's always limitations. I think the important thing with rhinoplasty is we're always making improvements. Perfection is just is always going to lead us down a path that's going to be disappointing, because obviously, again, no one really starts off with a perfect nose. No one will ever have a perfect nose. There's always these little flaws to every nose that makes it unique and individual, and those are the things that we're trying to improve with surgery. And typically we can get large improvements with these sorts of things, but crooked noses are definitely hard to do. There's different ways to approach it, and depending on the degree of how crooked the nose is, we have a slew of different techniques to address that. But at the end of the day,
they become reconstructive surgeries a little bit more than yeah. And as Prem says, you could grow your mustache to cover the nose, DJ. So.
That's why I got mine going right now. Yeah.
So we're running short on time, but we'll do the last one, which is what we want to talk about is functional status. So breathing status. So how do those functions? As DJ and I are both, ENT head and neck trained in the background. So we, like anyone that comes in that can't breathe or breathes worse, I would consider as a failure, no matter how good their noses look. So, and I know he agrees. So I guess, what do you want to say about functional status there, DJ?
Yeah, one of the things that I talk about a lot with patients, and I mention a lot in my Instagram posts and things like that, one of the fun parts about rhinoplasty is a good-looking nose typically functions really well. And so it's kind of fun when we're doing these surgeries. A lot of patients that I do cosmetic rhinoplasties on, they don't even realize that they've actually had a functional issue their whole life. They come in to see me. They have no problem. I have no problems breathing, doctor. I just want the nose fixed. And then I'll end up, fixing the nose from the inside out and doing everything. And then they come back in and they're just like, wow, I didn't even realize I had problems breathing until now I can really fully breathe.
Right.
It's obviously everything's intertwined with rhinoplasty. The way that it looks, it corresponds to the way that it functions. And we kind of have to think about the limitations to the changes we can make to the shape of the nose based off how it's going to impact and maybe negatively impact the function of the nose. But the main things that we're looking for, there's basically two anatomical regions that are called the nasal valves. There's the external, which is kind of like if you think about just the nostril and how well that's supported. Some people breathe in really strong and their nostrils will completely collapse, and we have to do things to strengthen that valve. And then there's the internal nasal valve, which we spoke about a couple times, and that's kind of more of an angle that's up here. And if you think about what breathe right strips do, breathe right strips work on that internal nasal valve to pop it open. And so there's things we can do to improve that. And then there's also the septum, which is a main component, and the turbinates, which are these kind of bony appendages with mucosa that come off the walls of the nose that are meant to stir up the air coming in, and that often are affected by allergies and things like that. So we can work on them to shrink them down a little bit. But function obviously is super important. It's always a goal of ours to improve, no matter what the goals of the patient are.
I think one thing too to highlight is that when you look at, especially the noses that we're posting, that we're putting on Instagram and other things like that, we're doing the way that DJ and I do it is very similar. We might have a little bit of different techniques, but they're a lot similar, and we kind of get similar looking results. And I think we're able to achieve things that are aesthetically pleasing, that are improved, that look good, look natural. But I think at the same time, we know that we've improved their breathing and certainly not hindered it or made it worse. And I think that's key because no matter how cute or good or whatever the nose looks like, when someone comes in and they are breathing on one side of their nose and they're like, wow, I haven't felt that in 20 years or something like that. There's not much that's cooler than that. That you've affected their life in a way that's like really, really profound. And that's really cool. So I agree 100% on that. And so I think what we're doing is good. And you can see that we're achieving these techniques now. And look at the noses that we have posted. They still look great. They look really good. So my whole philosophy is that you don't have to choose between function and the aesthetic. You can have both. You should have both. And not getting both, I think, is just a disservice to you if you're looking to get a rhinoplasty done. So
yeah, like you said, there's been a big shift in rhinoplasty over the last 30, 40 years, where it was basically just make it as small and acute as possible. And then we found out, 15, 20 years later that these patients were having extreme collapse. They were having all these issues with support of their nose and breathing. And at the end of the day, no matter how cute your nose looks, if it's stuffed up and it's not working well, you're not going to be happy with it. We've worked around that now. We've basically changed to what we call structural rhinoplasty, which is basically reshaping things without taking out things, because we know that's going to lead to long-term functional issues.
It's true. I mean, my dad's a plastic surgeon, and he didn't do a ton of rhinoplasty, but he's just he's watching, I know here. So he's extremely skilled. He's an extremely skilled surgeon, and so he would go, long time between doing rhinoplasties and get like really nice looking results that I see. But the things that I'm doing and I talk to him, the techniques, they're just like foreign to him, and it's not his fault. It's just the fact that like this field has advanced so much between his career and my career, and that what we do is very different than what he was trained to do and what they were doing, as it should, right? As it should for everything. So. Well, we appreciate you guys being here. We don't want to take too much time. If anyone has any, I guess we have like a minute or two for maybe a question or two if someone has one, but we appreciate it. I'm hoping to keep doing these lives and talk about different things. I'm sure DJ will as well.
Definitely.
And have a happy New Year, everybody. If that's it, then we're gonna head
Dr.
on out.
Lozada, Kirk is having a liquid rhinoplasty contest. So if you're in the Philly area, I saw that would be an awesome thing to win for the holidays. And then keep on following us. There's more exciting news and stuff like that always coming out from our standpoint.
You can't win, DJ. I just want to let you know you're out
I'll
of the
fly
running.
in for it. It's worth it. And everyone have a great, happy New Year's and stay safe out there. COVID's a little wild, so everyone be careful.
All right, awesome.
All right, guys.
I have to figure out how to stop this. All right, I'll see you. Bye, DJ.
Take care.